Good morning, everyone. Welcome to day 2 of the virtual Showcase of Undergraduate Scholars. I am Jessie Bowman in the Office of Undergraduate Research. This morning, we have an amazing session for you all. We've got everything from history, public health, medicine, and political science research, and fantastic students who are going to be presenting. And so we've got a little housekeeping. This presentation is being recorded, so all videos will be uploaded to our YouTube channel, and those links will be shared with you all. Questions are encouraged. So in your toolbar, there's a Q&A box or a button. So as the students are presenting and you're thinking of questions, go ahead and enter your questions in there so that they can answer those immediately after their presentation. And today we have a fantastic moderator. Dr. Chad Risco is joining us. So I'm going to turn it over to Dr. Risco and let him do an intro.
Hi, everybody. So I'm Chad Risco. I'm an associate professor in chemistry. I'm also the faculty director of the Office of Undergraduate Research, and it's a really great pleasure to be here and to moderate this session that, I think tracks across the university quite well and is going to show a real diversity in the kind of research and creative scholarship that our undergraduate scholars take on. And so, to keep me talking very short, I guess, and to turn the session over to you guys, it's my pleasure to introduce the first speaker, Elena Liu. So Elena, the floor is yours.
Hello, everyone. I'm going to go ahead and share my screen. All right. So we'll go ahead and get started. I have a lot to cover in my 10 minutes. So today we're going to be talking about the Spanish flu in post-revolutionary Mexico, which was from 1918 to 1920. Just to start off with a little background information on the Spanish flu, during this time, globally, about 500 million people contracted this illness. That's about a third of the world population at the time. And about 50 million people died. These are both estimates because we don't really have the exact numbers, but this was really a global pandemic. A lot of the research on this topic focuses on the United States, which is where the Spanish flu is thought to have originated, India, which had a particularly bad outbreak because of the conditions, the close conditions that people were living in, and also Spain, which had such a devastating impact there that this is where it gets the name Spanish flu. But when it arrived in Mexico from the United States in the fall of 1918, it really arrived to a fatigued, unstable politically and economically and damaged nation. To give you some more context, the Mexican Revolution the presidency had changed hands from a dictator to a president who was assassinated, a new constitution was drafted, and power changed hands a couple more times. And so Venustiano Carranza, who was the president during the Spanish flu outbreak, his administration was really focused on maintaining the stability of the federal government in Mexico. Here I have a map that just shows some of the daily death figures. You can see that the outbreak moved from the northern border down into Mexico. Along the northern border, you have about over 100 deaths a day in the fall of 1918. And so, as I mentioned, a lot of the research on this topic focuses on other countries. However, the intersection of these two events, the Mexican Revolution and the Spanish flu outbreak, makes it a really interesting area of study in Mexico in particular. A lot of prior research, however, focuses on this idea of a sanitary dictatorship and how the federal government kind of used this situation to further their aims of authoritative and centralized rule post-revolution. My own argument, or my own research, pushes back on this argument a little bit by talking about how the Mexican Revolution really limited the response that the federal government was able to have and made it a lot more off the cuff than prior research suggests. We'll talk about 3 ways in which the revolution limited the federal response during the outbreak of Spanish flu in Mexico. So moving right along to our first sort of area of focus is the emphasis on local authority. So things were already very decentralized in terms of power for the federal government and local governments post-revolution. However, you have a few events that kind of emphasize and reinforce this idea as the Spanish flu is entering Mexico. So on October 6th, which was very early as it was coming across the northern border, several federal offices were closed in northern Mexico because of outbreaks of Spanish flu among postal workers. And so not only did this close these federal offices, it also cut off a key line of communication between the federal government and state governments. Another important thing is the resources that were available for safety guidelines and recommendations. So as it came across the northern border, we start to see in Mexico City, which is the capital of Mexico, a lot of newspapers publishing information from the Higher Health Council about things that we're very familiar with today, wearing a mask, staying away from people who are sick, things of that nature. However, by the time that the flu reaches Oaxaca, which is a southern state of Mexico, around mid-October, they are asking, as we can see here, they are asking for guidelines to be published in their local paper from northern states rather than from the capital, which would have been much closer. And in this time, it's not like you can just send an email with this information, right? Time is very important, and they're getting this information not from the closer source, but from a Delgado Sanitario, which is sort of like a health department, a local health department. It is under the federal branch of the Higher Health Council, but you can also see here that rather than highlighting the Delgado Sanitario, they have the name of the doctor very prominently featured, which shows just how much it was important that the public was familiar with the doctor in terms of trusting the information rather than the federal institution that they stood behind. Next, we'll talk about how limited funding services were. Obviously, budgets were strapped post-revolution, so much so that the responses were so short that groups of private citizens came together in order to distribute medicine and import disinfectants from the United States. There was nothing available in Mexico, and so it all had to be imported. Unfortunately, a lot of times this came too late because the Spanish flu would pass into a region of Mexico. The federal government might send a sanitary brigade or something. However, usually it was gone within the next 2 weeks, and case rates had really dropped by that time. And so the response that anyone was able to have was very limited because that infrastructure and quick funding wasn't really there. Finally, the last thing I want to touch on is commerce lines. So we have boats, barges, and trains. There was a lot of uproar because the Mexican government basically allowed these vessels carrying sick passengers to dock or stop in Mexico, and just mandated that people who were sick could not leave the boat or could not leave the train or had to be quarantined to a certain area of the city. And so that caused a lot of outrage, obviously, because they were interacting with healthy people on these vessels, and then that is really what is thought to have caused the quick spread of the Spanish flu throughout Mexico, particularly as it pertains to the railway system. And so you have not only citizens, the press, but also people in those Delgado Sanitarios, those health departments locally, who are under the federal government asking for these rail lines to be stopped in order to really stop the spread. So those are the 3 main points that I have, and they really just illustrate how limited this government would have been in creating a sanitary dictatorship, and how really a lot of their moves had to be very off the cuff. I know that I glossed over a lot of things because of time constraints. I can go into a lot more detail about all this, but if you have time for questions, I believe I stopped sharing.
Yeah, Elena, that was great. And we've got maybe 3 minutes or so for questions. I guess I have one, I guess, just to kind of get started. And so you talked about the prominence of this doctor in some of the advertisements, right? So from one of the northern states. And I wonder if you can make a connection now to sort of the role that Dr. Fauci is playing, right, in the COVID-19 response here in the US.
Yeah, certainly. So I think there definitely is a connection there. However, the thing that I found most striking about those public advisories was the fact that the individual doctors were highlighted. So for example, when we look at guidelines on storefronts or online, we always look for stuff that has the little CDC logo, that's what we associate with true information about this pandemic in the United States or globally. However, in Mexico, this was not the case. It was really focused on local doctors. This doctor in particular, Dr. Cerqueda, had worked in the north, which is where the pandemic sort of first came across the border. And so that gave him a lot of local pull in terms of name recognition and being an innovative doctor, sort of coming up with solutions. I think there definitely is a parallel that you can make to Fauci. It's just the difference there on those official documents, I think.
Okay, cool. Are there other questions that I don't see any in the Q&A in particular, but if folks would like to chime in?
Elena, this is Jessie. Here, let me turn my camera on. I actually have a question. How did you get connected with this research opportunity, and what drove you or guided you to this particular research topic?
Yeah, so this has been an independent study for me this semester. I am an international studies student, and so my focus area is Latin America, and in particular, I've done a lot of research on Mexico and taken a lot of classes that pertain to that specific nation. And so I just sort of came across in my reading a lot of stuff, A, on the Mexican Revolution, and B, as the pandemic started, I started to see these photos of people wearing masks 100 years ago. This was basically almost a little over a century ago for us, which was really just striking to me. So I got more interested into the topic and was really interested to see how it connected to the Mexican Revolution, which I had learned a lot about in a few different classes. So that's really how I got interested in this research this semester.
Awesome. So there is one open question now in the Q&A, and maybe take a minute to respond to that, and then we will turn to the next speaker. So the question is, do you think looking back at previous pandemics could have helped our understanding of this one, especially in talking about the guidelines that you mentioned?
Yeah, I think very much so, especially as I mentioned, there's not a lot of research on this pandemic in Mexico. It's talked about in relation to other nations, but I think it's important for countries individually to look at how pandemics have played out in the past. Obviously, the guidelines are not so relevant. They were looking for cures 100 years ago and thought that they had them, which we know now is not really the case for viruses. However, there is that parallel. It's also really interesting to see how these governments were not able to get those cures or those medicines imported from the United States, and how that kind of parallels to the way that vaccines are being disseminated across the world now. So for example, in the United States, I would take a guess that maybe a majority of us here in this chat are vaccinated. However, in a lot of countries, even the oldest populations aren't vaccinated yet. And so the fact that that's not available and has to be imported from another country, I think draws a lot of parallels to this event in Mexico.
Well, awesome. Well, thank you very much, Elena. This was really great.
Thank you.
So I think we will now turn to the second speaker, and Rachel.
Hello, I'll go ahead and share my screen.
Okay, great.
Okay, awesome. So my project is on the impact of COVID-19 related restrictions on motor vehicle crash fatalities in Kentucky. I completed my research under my mentor, Dr. Julia Kostich. She is an associate director at the Kentucky Injury Prevention and Research Center, along with a professor at my college, the University of Kentucky College of Public Health. So to go ahead and get started, the purpose of my project was to determine whether activity restrictions in response to COVID-19 increased or decreased the state's MVC fatality toll. So MVC, which is an acronym that I will be referring to throughout this presentation, stands for motor vehicle crash. So some reports on the impact of COVID-19 related restrictions on MVC fatalities have varied pretty widely in previous studies that have been done throughout this past year. So some investigators have reported that reductions in traffic volume have actually reduced fatalities, which is what, I would have hypothesized without any previous background on the subject. But other studies have actually found increases associated with an increased incidence of high vehicular speeds due to that low traffic volume. So some preliminary data does indicate a modest overall increase in the 2020 MVC fatalities as compared with 2019. And also Kentucky has always had kind of a relatively high rate of MVC fatalities, and this is due to our mountainous roadways, our rural areas, and also, a persistent underuse of safety belts and other safety precautions on the road. So to go ahead and get into my data, so in week 11 of 2020, on March 16th, that's when the pandemic really started to affect our lives, especially here in Kentucky. So on March 16th, in-person classes were canceled and restaurants were shut down in Kentucky. And this day can be seen on that first graph, the first yellow vertical line. So that's going to be March 16th. And then in week 20 of 2020, Andy Beshear announced that groups of 10 or less people were allowed to gather, socially distanced, of course, and restaurants were permitted to open at a small 33% capacity. And that date, May 22nd, can be seen by that second vertical yellow line in that first graph. And so I'll continuously kind of report back to these two dates, just because that small period does have a lot of significance, with MVC fatality tolls directly related to those restrictions for COVID-19. So I sought to determine, whether activity restrictions in response to COVID-19 increase or decrease this fatality toll. And I did this using some daily MVC data, and this was provided by the Kentucky Office of Highway Safety. And so using all of this data, I did compare these fatalities by week in 2020 with those in 2019. As you can see in both graphs, both of those, the top one kind of goes by week, and the bottom one goes by week as well, but it kind of shows more the total of the MVC fatalities throughout the year. So that's kind of a running count of these fatalities. So I isolated the period between March 16th and May 22nd, which again are those two yellow lines. And so those are the most stringent statewide activity restrictions. And then I also analyzed the total MVC fatalities by week as shown in that second graph. So to kind of go ahead and get into my results, MVC fatalities declined immediately following the announcement of these activity restrictions, which was on that date of March 16th. So you can kind of see in that first graph, there was a pretty sharp decline from week 11 to week 12. So in week 11, there were 14 MVC fatalities in Kentucky, but in week 12, there were only 3 fatalities. So that is a pretty sharp decrease, and that could be due to those initial statewide restrictions and kind of the scare of the pandemic, something we've never really experienced before, and those restrictions that were put in place by our governor. And then, so ultimately, after those first initial 2 weeks of these new restrictions, the 2019 total actually fell behind the 2020 total of MVC fatalities. And so this was statistically significant. This was 8.33% of a decrease. So then the total MVC fatalities for 2020 did eventually exceed that 2019 total by a slight margin that was insignificant, and that data can be seen on that second graph. So the total MVC fatalities were higher in 2020 than in 2019 from the months of January to June. However, in July, these 2020 fatalities did surpass the 2019 fatalities. And this can be seen in that second graph as well. So if you look at that orange line and that blue line, throughout the entire year from January to early July, that orange line is pretty much above that blue line. But when you get to that mid-July point, those lines kind of come together and you can see how those fatality totals pretty much stay the same throughout the rest of the year. And so these statewide activity restrictions, they may have reduced Kentucky's motor vehicle traffic and lowered these fatalities immediately following their imposition, probably due to the scare of a pandemic. But this effect was very short-lived, and it did fail to lower these fatalities overall, considering the pandemic is still ongoing. So maintaining these desirable effects of public health actions, as we can see in many public health initiatives, including this one, requires enforcement and reinforcement of these restrictions. So these fatalities are rare events in the context of vehicular traffic volume, and they actually might not be sensitive to policy initiatives that are intended to reduce unnecessary travel. And this is particularly true in rural areas such as Kentucky, with some places that have suboptimal roadways. And actually, there may be an increased risk of these fatalities that are reflected by factors such as speed and distraction, not necessarily volume of traffic. So one thing I would like to look at in future research, would be to compare these factors like speed and distraction, and also to kind of look at our state as compared to other states and how those fatalities kind of relate to policy related restrictions, because different governors have reacted differently to the pandemic and have put in place different types of restrictions. So I think it would be very interesting in future research to go ahead and compare those factors as well. And that's all.
All right, great, Rachel. That was fantastic. So completely unexpected for me as well when you started to tell the story. Because, obviously driving around Lexington, when you did go out during those few weeks, the volume of traffic was much lower.
Mm-hmm. I know, it's very, very surprising for me as well, definitely.
Yeah. We do have a question. Jessie asked a question. She says, great presentation. What do you find most surprising about what you found?
Yeah, definitely. I think really what I found most surprising was, the fact that this volume of traffic doesn't necessarily, affect the number of fatalities. Because when I think of, being on the road, right, like having a lot of cars would be like much scarier and much more dangerous than having not as many cars. But in reality, that may not be the case. And it is probably, more down to the factors of speed and distraction. And this could be true, in suboptimal roadways, like in rural areas of Kentucky, but also, in a highway setting, which is, why I think it might be interesting to look at other states that have more highway roadways, and see how that kind of compares to those rural roadways.
Sure. So do you have the data perhaps to be able to break this down by county, and population as well, or?
Yeah, so the way that the Kentucky Office of Highway Safety kind of gives out this data, it is by county. You can get that different information. I don't have it on me right now, but that is something that could be looked at, definitely.
And just a last question that I have is, so 2020 was perhaps maybe supposed to be sort of an odd year, right? It's even, but you know what I'm saying. But how have you looked at other years, like 2019 compared to 2018, right? I mean, would there be anything significant in 2019 that would affect those numbers, or like, I guess a more longitudinal study?
Yeah, so I haven't looked very closely at data from 2018 and 2019. I did kind of look at a generalized picture and how, 2017, 2018, 2019 all had pretty similar fatality totals like at the end of the year. So those totals were pretty close together. And the same with 2020, right? Like 2020 and 2019 were approximately the same at the end, even though 2020, insignificantly passed 2019 just by a few fatalities.
Sure. Okay. I see Brooke has a question, and if it's really quick, we can address it, and then we'll move on.
Awesome.
Yeah, so I was curious if there were any underlying health conditions that were controlled for when assessing some of the individuals that were involved in these motor vehicle collisions.
Yeah, that's a good question. No, we did not control for any of those. This data is purely numerical.
Okay, cool. Well, again, thank you very much, Rachel. This is fantastic. It's always good when things are unexpected. So
Thank you.
all right, so let's move on to the next presenter, which is going to be Kelsey Gatton. And Kelsey, are you ready?
Yeah, I'm ready.
Okay.
Okay.
And Anamarie.
Yes, we will be presenting together.
Okay.
So
Go ahead.
Anamarie and I will be talking about our research regarding identifying barriers to patient discharge timeliness. And we did this alongside our faculty mentor, Dr. Karen Clancy in the College of Health Sciences, and our practicum preceptor, Dr. Talari, who was actually at our site. So our goal of the project was to determine the primary barriers to timely discharges through a clinical leadership practicum experience at an advanced tertiary care teaching hospital. So the literature states that the discharge efficiency can lead to patient care errors, longer lengths of stay, higher cost, and diminished patient satisfaction. So we conducted this project alongside the efficiency affinity group with Dr. Talari to, one, determine primary barriers to timely discharges and reduce the time between discharge order and final discharge to 2 hours. So our metrics included, one, having a discharge order placed before 10 a.m., and then second, having a final discharge by noon, and that would be a DBN, which you may hear throughout the presentation. So our data sources came from Sunrise Clinical Manager, and that is their electronic health record system, and that we retrieved our quantitative data from there, which was patient information and discharge times. And then we used Volt to communicate with patient care staff, and that was more of our qualitative data to identify barriers through communication. So we kind of divided our data collection and analysis into 2 groups. So the main group was just all patients who had a discharge order placed by 10 a.m. And then the subgroup was for the M20 list. So the M20 list identifies patients in SCM who should have a 10 a.m. order and be discharged by noon the following day. So during team huddles at around 2:30 the day before, the patient care staff identified patients to be placed on the list by 4 p.m. the previous day. So they would be identified as an M20 patient. So data collection occurred 3 to 4 days per week in September and October of 2020. So we looked at after 4 p.m. the day before for M20 identifications. And then at 10 a.m., we looked who had a 10 a.m. order, who didn't regarding the M20 list, and then just total with that main group. And then we looked at on Volt if they expected any barriers to be discharged by noon. So then at noon, we looked at who is still in the system. So if they're still in the system, they're not discharged. And then we look at the actual barriers that were faced to not have a discharge by noon. So this is an example of one of the spreadsheets. We have very many of them and how we collected our data. So looking at bed numbers, did they have a 10 a.m. order, were they discharged by noon? And then of course, all of our communications there on the right, and everything is de-identified data. We just blocked out the team member names just for, personal reasons.
So continuing on with methods, as Kelsey mentioned, all of our data that we did collect was de-identified and entered into separate spreadsheets. And then with those spreadsheets, we were able to utilize and record and analyze data, specifically quantitative data, as well as communication records and barrier totals. Lastly, we demonstrated analyzation by using Google spreadsheets to calculate counts, percentages, sums, and averages. As you can see in our table here that we have, each day that we collected data, we entered the numbers into the system, and then it calculated our into the sheet, and then we calculated our percentages. So we were able to take those with our data. So, and then for our results, there were a total of 165 patients involved, and our final sample size was 64, with 101 of those patients being excluded due to no staff response or successful discharge before noon. The barriers and delays were divided up into 11 groups. And as you can see, some of those groups were patient decompensation, ambulance, and so on and so forth. And then the two largest barriers that we determined were ambulance delays as well as treatment scheduled. And then this is our graph that we came up with after collecting all of our data. As you can see, the two most popular delays, as I mentioned, were ambulance delay and treatment scheduled. So there were a lot of patients who had to wait on ambulances, and then who also had other treatments that they had to receive before they were able to be discharged. So that is our final data collection our results that we came up with the barriers, the most popular barriers.
And then I'll go ahead and talk about the M20 subgroup. So we had 84 identified, 50 of those had a 10 a.m. order, and 42 of those were discharged by noon. So that was about a percentage of 84. So then we also looked at, why do M20 patients not have a 10 a.m. order if they're identified the day before that they need to be discharged by noon? So that came down to communication and new patient decompensation.
And then for our main group results, there were a total of 116 10 a.m. orders with a total of 47 discharges before noon, which came out to be 40.5%. And so we also collected some of the reasons as to why 10 a.m. orders were not identified on the M20 list before. And that was just a few of the staff not being informed, and there being some miscommunication issues, as well as people not being aware of what the M20 list is, and then kind of some transportation changes that made discharges before noon impossible, and then some patients having some questionable discharges and not being sure if they were able to leave by noon.
Cool. So discussion and limitations. So the main contributors to limited discharge efficiency were transportation delays, scheduled treatments, and as we kind of talked about in the last slide, a lack of communication and understanding. So delays are not always in control of patient care staff, but scheduling early, communicating with staff, and completing discharge requirements as early as possible could improve efficiency. And we did relay all this information to the affinity group, and we kind of recommended that they educate staff on the M20 list and kind of work on doing things as early as possible, but we do know that that's not always the case. And then some limitations included a limited availability to collect real-time data. So we are on SCM at 10 a.m., noon, and 4 p.m. On the dates that we collected. So it had to be real time. There may have been discrepancies in converting qualitative data to quantitative. So our communications on Volt, transferring that into numbers can be difficult. And then author access to SCM. So I was the only one who had access because we kind of wanted to just keep access to such a private tool, to a minimum. So yeah, and that is our presentation.
Great, thank you guys. So you just out of curiosity, I guess, ambulance delays is, strikingly big, right? What might be the cause there? And is it typical or not that people, when they're discharged, they go by ambulance?
Anamarie, you could take that one if you'd like.
Yeah, of course. So it was kind of interesting to see the ambulance delays. That was something that came up a lot, as you can see, with it being our #1 barrier. And a reason for that was because the company, I think through UK healthcare that they were using, just was not able to get transportation until the afternoon. I think ambulances were so delayed. So even if they did place that discharge order by 10 a.m., the patients still were not able to get out until 1 o'clock, 2 o'clock, later in the afternoon. So from the updated information, they have hired a new company, so that may change the barrier, which could help with the earlier discharges and possibly patients being out by noon. So we're not exactly sure what the updated status is on that, but it could help in the future.
Well, that's really great then that the data you collected and the results from the analysis is already leading to maybe some structural change, right? That might help in this case. So congratulations on that. We are out of time, so I think we are going to say thank you. That was an excellent presentation, and I like the teamwork that you have here. So this is great.
Thank you.
Thank you.
Thank you, Kelsey and Anamarie.
Thank you.
Okay, so let's turn now to Brooke Woolsey. I see you there, Brooke, I think, yeah.
Yeah, it's not allowing me to share or start my video, I don't think.
Let's see. Jesse, do you know?
Try it now, Brooke.
Okay. Yeah, it's still not letting me. I'm not sure.
Okay, so you have all of the access. It may be something.
Okay.
Do you want me to pull up your symposium presentation?
I think. A second. Let me see if I can do it now. Okay, I've got it to work.
Okay.
Okay, so sorry about that, everyone, but my name is Brooke Woosley, and I have been working with Dr. Rachel Hogg Graham in the College of Public Health on a study called Exploring the Integration of Clinical and Community Organizations to Address Unmet Social Need, a social network analysis. So are we getting what we pay for? The graph on the left shows the percent of GDP spent on healthcare in various developed countries, and you will see that the United States spending roughly 17% of its GDP on healthcare. The life expectancy across these same developed countries, and you will see that the United States is actually one of the lowest life expectancies at 78.6. So while the United States spends the most of its GDP on healthcare across various developed countries, it has one of the lowest life expectancies across these same countries. So what does make a person healthy? This graph shows that roughly 20% of an individual's overall health is attributed to healthcare, and the remaining 80% is attributed to factors such as socioeconomic factors, which could include education, job status, or income, and physical environment, as well as health behaviors, which can include tobacco use, diet and exercise, and alcohol use. So there are new strategies to address health. We want to address social and economic factors influencing patients' health. And to do this, increase collaboration between public health, community, and healthcare sectors is a strategy across public health research. However, very little is understood about the characteristics of these partnerships and how they facilitate patient linkages across sectors when patients present with unmet social needs. So the program to analyze, record, and track networks to enhance relationships partner survey was used for the study, and this is a social network analysis tool. Respondents were identified by a large hospital system where they selected organizations they commonly partner with when patients present with unmet social needs. And through this, 28 organizations in Fayette County were identified for the study. Social network analysis methods were used to measure the quantity and quality of relationships between organizations in addressing unmet social needs. And some key measures of the study included value, trust, and network structure. So this is a social network map of the Fayette County study, and it is based on most commonly identify with. When we ask a referral or client assessment measures for when patients present with unmet social need. The social network map becomes very integrated, meaning that most of the partnerships included some sort of referral or assessment. However, when we asked if there was any resource or data sharing across sectors and between the left, you will see how the blue nodes or the clinical organizations are more clustered together, meaning that they work as the community-based organizations or the government-based organizations. And you will again see how the community-based organizations are more clustered there at the top left in the network map shown on the right. So while most of the organizations had some sort of referral or referral interaction only on a weekly basis, where the clinical and community-based organizations started to refer and interact with one another in these efforts. And you will see the graph on the left showing that on an everyday basis, they are again working within themselves more than reaching across sectors. So public health is historically underfunded, and this holds true in the efforts to address unmet social needs in the Fayette County community. So when we asked if the partnerships had some sort of funding support across sectors, you will again see how this map is expanded, showing that there are less partnerships in these efforts, but you will also see some of the open response questions that we got from the different sectors, and you will see actually in all of the sectors of clinical, community-based, or government-based, they are all underfunded in efforts to address unmet social need. So we asked the organization some additional characteristics. So when we asked the organizations to identify if the partnerships that they had that improved the capacity of the community to address unmet social needs, led to improved services or supports, or had been informative only. Again, in these maps, you will see how they work in homogeneous manners, meaning that they work within themselves more than they span across one another and collaborate together in efforts to address unmet social need. So some conclusions is that health and community-based organizations continue to work in silos with very limited integration across sectors. So despite high levels of trust and value in the network, most organizations report efforts to address unmet social need as only somewhat successful. So improved resource and data sharing, in addition to development of funding strategies to incentivize cross-sector integration, may help to improve community efforts to address social needs and improve health outcomes in the Fayette County community. So one limitation of our study is that we examined a single network, which was Fayette County, but the respondents were also identified and bounded with a hospital, which would mean that we weren't able to include every organization in Fayette County that may be engaged in the work to address unmet social need. However, we plan to collect data in 27 additional communities across the country to really start to understand the quality and quantity of relationships to address unmet social needs across clinical, community-based, and government-based sectors. So thank you for listening, and let me know if you have any questions.
Thank you, Brooke. That was fantastic. I guess just a quick follow-up question. You said there might be ways to incentivize, right, communication and networking. What might an example of that be?
in the future, there's research indicating that providers may be paid on a value-based level instead of a quantity-based level, meaning that they will be based or paid on the outcomes of their patients rather than the amount of patients that they see. So if there was a system set up like that where we could measure some patient outcomes, I think that would incentivize provider and other community networks to really start to integrate with one another. And again, going back to addressing social and economic factors, we know that that plays a much larger role in improving overall health of individuals and populations. So if we're just doing clinical care for patients, we're only potentially affecting their health 20% of the time. So again, just incentivizing the providers to start reaching out to community resources and networks to address unmet social need would help them to improve the health of their patients.
Okay, and you have one question in the chat, and that's from Jessie, and she first says interesting project, and then asks, what challenges did you encounter during your research?
So some challenges included some non-response, and a lot of the, you couldn't really understand the quality of the relationships without really interviewing some of the organizations. So again, in those additional 27 studies in those different communities, we plan to have some more personal interactions to really start to understand the quality and quantity of those relationships.
Okay, fantastic. All right, well, thank you very much, Brooke. That was a great presentation and some pretty interesting research that you presented.
Thank you.
So I think we will now turn to Lindsay Beechem.
So yeah, I'll share my screen.
Okay. All right, take it away.
Okay, so my name is Lindsay Beechem, and I'm going to talk to you all today about the relationship between sleep and Alzheimer's disease. My main faculty mentor was Dr. Marilyn Duncan, but I also had a lot of other professors who also worked on the project with us. So Alzheimer's disease is a neurodegenerative disease that is characterized by profound loss of memory and cognition. It's also defined by amyloid beta plaques, neurofibrillary tangles, and neuronal death, all of which cause neuroinflammation. One role of sleep is to clear toxic proteins, such as amyloid beta, from the brain. Therefore, sleep deprivation is associated with increased amyloid beta levels and subsequent neuroinflammation. Previous studies have also shown that Alzheimer's patients have disrupted sleep-wake patterns, showing increased nighttime awakenings and inadvertent daytime napping. And these sleep alterations often precede the actual Alzheimer's diagnosis. So we set out to see if sleep has a causal effect on the progression of Alzheimer's disease. Specifically, we ran a few pilot studies investigating whether chronic disruption of daily sleep-wake cycles with sleep fragmentation increased amyloid beta 40 and 42 levels and neuroinflammation in the hippocampus of transgenic Alzheimer's disease mice. We decided to look in the hippocampus because that's a very important structure in memory, and also it's where Alzheimer's tends to have its first effects in the brain. And we used a transgenic Alzheimer's mouse model that has 3 mutations associated with familial early onset Alzheimer's disease, so it will express some amyloid beta and tau protein. The way we went about doing this is for each of our pilot studies, we used mice of slightly different ages, but in each study we had 2 groups. One was a sleep fragmented group, or SF group, and one was an undisturbed sleep group, or US group. We had sleep fragmentation sessions that lasted 1 hour each, and they occurred 4 times a day, 5 days a week for 4 weeks. And during these SF sessions, for those 1 hour periods, we would keep the SF mice awake by adding novel toys to their cages or by lightly tapping them with a paintbrush. And all the while, we would leave the undisturbed sleep mice undisturbed, allowing them to sleep as normal. After the 4th week, mice were anesthetized, and we harvested their hippocampus and cortex for analysis. So if you look in the results on the bottom left of the screen in figure 1, we can kind of see the graph of what a typical sleep would look like during week 1 and week 4 of our sleep fragmentation protocol. Those gray vertical bars represent the 1-hour sleep fragmentation periods, and the blue line is the sleep fragmented group, while the orange is the undisturbed sleep group. So as you can see, during those sleep fragmentation periods, we were successfully keeping the sleep fragmented mice awake, as shown by those low percent sleeps that we can see during those gray bars, while mostly leaving the undisturbed sleep group undisturbed, allowing them to sleep as normal. What's really interesting is by week 4, we start to see the sleep fragmented group kind of making up or trying to recover some of that lost sleep that we're imposing on them by sleeping a little bit more in between those fragmentation periods and also sleeping a little bit more at night when mice tend to be more awake. So they're kind of trying to recover that lost sleep that we're inducing with our protocol. We found that sleep fragmentation increased hippocampal neuroinflammatory markers. So we looked at 4 different classes of neuroinflammation and saw significant increases in the amounts of reactive microglia as a result of the sleep fragmentation versus the undisturbed sleep group. And probably the most interesting data is that we found sleep fragmentation increases hippocampal amyloid beta levels. So we looked at 2 different forms of amyloid beta, both amyloid beta 40 and 42. 42 has 2 extra amino acids, so it's a little bit longer and can aggregate more easily, making it the more neurotoxic form. We also used 2 different buffers to extract the amyloid beta, both DEA and RIPA. DEA extracts more of the amyloid beta monomers, while RIPA extracts more of that aggregated amyloid beta that's a little more dangerous. And interestingly, we found that chronic sleep fragmentation does significantly increase the hippocampal levels of the RIPA-soluble A beta 40 by 20% and the amyloid beta 42 by 64% compared to the undisturbed sleep group, which is a very large increase, very interesting to find. So in summary, the sleep fragmentation of our mice provides a model for the disrupted daily sleep-wake patterns of Alzheimer's patients. The reason we chose to fragment their sleep in 1-hour periods instead of just doing like a block of sleep deprivation is because it more mirrors how Alzheimer's patients will wake up throughout the night or fall asleep during the day for naps. We also found that the sleep fragmented mice had reduced sleep during our SF intervals, but then spent more time sleeping during the dark phase, indicating some recovery of sleep loss from the SF sessions. Protein levels of amyloid beta 40 and 42, as well as neuroinflammation markers in the hippocampus, were significantly higher in our SF mice, leading to the progression of Alzheimer's pathology. We did not see any significant changes in the cortex, and that could possibly be because Alzheimer's pathology occurs earlier in the hippocampus and only later spreads to the cortex. So maybe if we had drawn out the experiment longer, we would have seen changes in the cortex, and we also might have seen more changes, more increases in neuroinflammation, since we tend to see an increase in amyloid beta first that causes the subsequent increase in neuroinflammation. Fragmented sleep may play a role in limiting the amount of amyloid beta cleared from the brain, resulting in this increased A beta deposition and subsequent neuroinflammation. And finally, if future rodent studies support these findings, that chronic fragmentation of the daily sleep-wake rhythm advances Alzheimer's pathology, then improving sleep consolidation would be a potential therapeutic strategy for reducing the progression of Alzheimer's in humans. And I will now take any questions.
Great. So in terms of, well, one, since I woke up at 1 in the morning, I'm a little bit worried. I guess just, can you give a sense as to, you said you selected mice of different age. I mean, what does that sort of correlate, I guess, those ages of the mice that you use in terms of if you wanted to try to make a correlation with human, populations?
Yeah, so we know age is a big risk factor for those with Alzheimer's disease. So the older you get, the more likely you are to have Alzheimer's. So we kind of tried to mirror that in our mouse models. So we use 8-month, 11-month, and 14-month-old mice. And we found like the most significant effects of the amyloid beta definitely in those older mice. But in those 14-month-old mice, because they were so old, they had a lot of amyloid beta anyway, so the sleep fragmentation protocol didn't seem to increase it as much. There was probably a ceiling effect where just they already had so much amyloid beta that the sleep fragmentation didn't increase it even more. But in our 8-month-old and 11-month-old mice, we did see that when they had the sleep fragmentation protocol, that their levels were increased.
Okay, all right. And then Jesse asks if your research has affected your sleep habits.
Yes, so I definitely try to get a lot more sleep now. Between this study and also my lab just does a lot of different studies on sleep in general. It's taught me the importance of it and how sleep does have a lot of effects besides just Alzheimer's, but also with like memory and just daily functioning. So I try to get a lot more sleep now.
Sure. So it sounds like maybe you should start talking to some of our public health researchers that we have in the audience today too, and maybe start a campaign, for our undergraduates on campus to get more sleep.
Yeah, definitely.
All right. Awesome. Well, that's great, Lindsay. Thank you so much. Okay. So, yeah, we're going to turn to Katie Land.
Okay, let me share my screen. I'm going to use this laser pointer. Okay. Oh, well, hold on. I can't. All right. So hello, everyone. My name is Katie Land, and I'm a senior here at UK. I do research with Dr. Patrick Hannon in the OBGYN department at the College of Medicine, and we study environmental toxicants and their effects on female fertility. So specifically, our lab studies phthalates, which are a class of chemicals that are used as solvents and plasticizers in a multitude of common consumer products, including personal care items, cosmetics, food and beverage containers, car upholstery, building materials, and really so much more. And because of their widespread use, avoiding exposure is nearly impossible. Additionally, because phthalates are endocrine disrupting chemicals, we know that exposure could disrupt ovarian function. However, the direct effects on the process of ovulation are largely unknown. And so humans are also exposed to a mixture of phthalates on a daily basis. So this study utilizes an environmentally relevant phthalate mixture. And this is a unique approach because the majority of other studies investigate only single phthalate exposures. And you can see the composition of this mixture in the green table on the left of the slide here. And this mixture was derived from a study directed by our colleagues at the University of Illinois that measured the levels of phthalates in pregnant women. And so, again, because the direct effects on ovulation are unknown and because women typically have a higher exposure profile to phthalates, we study the effects of these chemicals on ovulation directly. And so briefly, ovulation is the release of the egg from the follicle, which is initiated by the luteinizing hormone surge, which I will refer to as LH, or clinical treatment of human chorionic gonadotropin, which I will refer to as HCG, and is essentially just a more potent analog of LH. So this surge of LH or HCG also triggers extracellular matrix remodeling, or ECM for short. And this aids in, it's required for successful ovulation because it aids in follicle wall breakdown. And so these LH or HCG induce increases in various proteinases in the matrix metalloproteases, or MMP for short, and in the plasminogen activator families, or PA for short, facilitate this required remodeling of the ECM. And so you can see that pathway laid out nicely here. And so we essentially did this study by isolating individual mouse ovarian follicles and putting them into culture with different treatment groups, which you can see in this blue box here. So those treatment groups included DMSO alone, which is not an ovulatory stimulus, and it served as our vehicle control. HCG alone, which is an ovulatory stimulus, and it's also that LH analog that I previously mentioned. And HCG plus different doses of the phthalate mixture ranging from 1 to 500 microgram per mil. We then visually assessed ovulation and measured expression of ovulatory mediators involved in ECM remodeling. And so this green graph right here is our ovulation assay, and it's our most striking data. The y-axis represents ovulation percentage, and the x-axis represents our different treatment groups. And so as you can see, when the follicles were treated with no ovulatory stimulus, ovulation occurred at an expected 0%. When treated with the ovulatory stimulus alone, ovulation occurred at an anticipated 80%. But as we increase the dose of the phthalate mixture, we see a dose-dependent decrease in ovulation, with this highest dose of the phthalate mixture being statistically equivalent to the group that did not receive this ovulatory stimulus and did not ovulate. And so these blue graphs up here represent gene expression of mediators in the PA family, and the orange in those in the MMP family. And so we see that the phthalate mixture decreased expression of PA inhibitors SERPIN1 and SERPIN-B2 when compared to the HCG control group. Moving along to the MMP genes, we also see that the phthalate mix exposure decreased the levels of the inhibitor TIMP1 when compared to HCG. And so the decreases in these three inhibitors perhaps might be why we observed increases in other MMP genes when treated with the phthalate mixture. So specifically, we see increases in MMP9 at 11-hour, MMP14 at 4 and 11-hour, MMP16 at 4 and 11-hour, and MMP19 at 11-hour. And so although these increases in these MMPs may be compensatory, they're not functional because we still see a decrease in our ovulation rates and decreases in ADAM-TS1 levels, which is a crucial proteinase in ovulation also. And so collectively, exposure to the phthalate mix leads to alterations in key ECM remodeling genes, likely resulting in dysregulation of remodeling during ovulation, which is potentially leading to inhibition of ovulation. And so in conclusion, these data support recent evidence suggesting that phthalate exposure may be a potential contributor to infertility in women, along with the negative health effects that are associated with infertility. So thank you, and I am happy to answer any questions.
Yeah, thank you, Katie. So I think to start, I'm interested by a comment that you made at the beginning that said that women tend to have higher exposure rates to phthalates.
Mhm.
So why would that be? This
is primarily due to their use in cosmetics. Their use and lots of personal care items like shampoo, conditioner, but women typically have a higher exposure profile because they're so commonly used in cosmetics.
Okay. Then I guess I'm used to them thinking about them in plasticizers and things. So that you would think, would be a pretty wide-ranging exposure.
Yeah, so pretty much everyone is exposed through being used as plasticizers through like personal care items like shampoo and stuff, as well as like car upholstery, building materials like carpeting. Yep. But yeah, women would have typically an increased exposure profile because of cosmetics.
Okay, and so Jesse has a question then, first grade presentation that asks, what's the best way to reduce phthalate exposure? And I guess, I can follow that up too, or just add to it. And is this something that maybe, regulatory agencies should start to get involved in terms of, the use of phthalates in these different products?
Yeah, so I know a lot of brands are like starting to promote themselves as being phthalate free. So as far as like reducing your exposure, you could potentially purchase like brands of shampoo and cosmetics that are phthalate free. But as far as making a statement as if like phthalate should be banned or something, this study wasn't necessarily designed to like make regulatory statements, but some countries are starting to limit or ban the use of phthalates, especially in like children's toys that are like going to the mouths of children. Great question.
Okay, awesome. Are there any other questions? Okay, if not.
Yeah, I had another question.
Yeah, go ahead, Jessica.
It's in the Q&A box. I just put, if you could do this again, Katie, is there anything you would do differently or change?
As far as just the study in general, phthalates are also rapidly metabolized in the body. I wouldn't recommend doing it differently, but that is something we're going into next. So like, what are these metabolites doing? How are they affecting ovulation? I think is something that we're starting to look into and a good question to ask.
Awesome. Okay, well, thank you very much, Katie. This was great. Yeah, so I guess we will turn to our last speaker, which is Remy Allen. We're going to change gears, I guess, again, in terms of the topic area here.
Yeah, following up all these really quantitative database things with some political science. So
yeah,
I can go ahead and share my screen. All right, am I good to go?
You are, sir.
All right, thank you. So hi, my name is Remy Allen. I'm a senior presenting this paper in research as my capstone for the Honors College. This was based on research that I've done for the past couple semesters with my advisor, Dr. Daniel Mori. It's been on military occupations, both during and post-war. So I started by assisting him for research credit in coding historical conflicts based on whether they involved or led to military occupation, as well as the circumstances of why they did or didn't. The idea for my research here started when I was tasked with coding the early 2000s invasions of Iraq and Afghanistan. A lot of researchers and sources on the internet casually refer to both these scenarios as military occupations by international coalition forces. But that didn't seem right to me. Based on the definitions we were using as the baseline for this research, I believe that involvement in Iraq should be, but in Afghanistan it should not, contrary to what most theorists had argued. I made this argument based on the differences between each scenario post-conflict, mainly that the level of involvement that foreign governments had on the state rebuilding process in these two states was different in character, implying different levels of control and influence from that so-called occupying force. So in very simple terms, my paper and research here are making that argument that current definitions for occupations are flawed. It gives different interpretations based on these vaguely worded definitions that leads to competing classifications of really complex geopolitical scenarios, which could devalue future research that's dependent on those definitions. So just to give a little bit of history background, military occupations have been a recurring theme in international law terms. Multiple conferences throughout the early 20th century worked to categorize occupations so that they'd follow the rules of war and be subject to international law. The 1907 Hague Regulations was one of the first documents that truly defined it. They simply define an occupation as a territory identified as land of one state that has administrative authority placed over it by another hostile state. The Geneva Conventions after World War II kind of expanded these definitions to include territorial control that didn't have to occur with conflict beforehand. Like when Germany invaded Czechoslovakia in the late 30s, there wasn't real military conflict there. They kind of just took it over. Those are just a few examples that show how these definitions have been expanded, refined, reworked constantly over time, but specifically starting with the 1900s. So now I'm going to move into these modern examples that I'm using as like my trophy examples of why these definitions can be really confusing. The Iraq War is probably the major US involved conflict of my lifetime. However, the actual invasion lasted less than 2 months. In that time, the entire party of the government led by Saddam Hussein had collapsed and fell under coalition force jurisdiction. Essentially everyone in theorists and political science agree that Iraq post-May 2003 represents a military occupation. So next is the other major international conflict, the conflict in Afghanistan. This was a little different as coalition forces invaded Afghanistan in late 2001, but it was a lot less military personnel, a lot less ground combat by our forces. Most of the ground combat was performed by the Afghani Northern Alliance, who was a military front of Afghani locals who we were allied with. They were actively resisting Taliban forces and continued to do so with our assistance after we got involved. We mainly performed bombing campaigns and special forces operations as opposed to the massive ground invasions that we would do in places like Iraq. And so this is where my argument comes in, is that most theorists argue that this is also an occupation by coalition forces. Both of these scenarios seem very similar at first glance. A primarily US-led international coalition of forces invades a Middle Eastern country led by someone or some group that they deemed a threat to international security. They both involved relatively short-term actual conflict and very long-term stationing of troops and influence on the rebuilding of that state. The main difference is the amount of influence and interaction that the US and coalition forces had in that process. In Afghanistan, the UN and US and coalition forces did help facilitate a lot of those processes, but Afghani delegates from both the Northern Alliance and all the local governments were majorly involved in the voting process, and that established the multiple temporary governments throughout the 2000s. They created important governmental foundations like a constitution and voted on all those decisions with hundreds of delegates from areas of Afghanistan. Contrast this with post-Iraq or post-conflict Iraq, where local government had pretty much no say in the new process. Multiple US-run organizations like the Office of Reconstruction and Humanitarian Assistance, which was later overtaken by the Coalition Provisional Authority, facilitated nearly all aspects of Iraqi administration. These offices made sweeping administrative decisions that completely removed legacy Iraqi officials from government, disbanded the military, and worked to restructure the entire economy. So while coalition forces were certainly involved in both cases, the case of Iraq shows a clear demonstration of sole administrative authority by coalition forces, which would justify its classification as a military occupation. Afghanistan's case, however, shows that native Afghani leaders really had most of the power and say in the governmental decision-making and created those interim governments, held their own elections, and drafted their own constitution without express command of foreign forces. So the takeaway point is that these scenarios that become classified as occupations are just way too complex, with far too many competing variables and ideas that categorizing these situations using one-sentence definitions is not helpful, really. A potential solution would be normalizing the process of each theorist that utilizes occupation data, making arguments for why the occupations they use in their arguments are occupations, or at least specifying the particular variables they'll focus on to classify it that way. And that's it.
This is very good, Remy.
Thank you.
To some extent, I'm glad to see this problem with language is not just in our own research field.
Yeah.
where you know we have multiple definitions of things, right, that can complicate, right, communication and make it more difficult, I guess. So would people maybe try to argue, though, that you're trying to maybe, you know, thread a very thin line here, you know, thread a needle between sort of the differences between occupation in Afghanistan and Iraq, or do you think, you know, that these differences are you know, would be considered significant, right, if you were to try to put some numerical value to it?
Oh yeah, sure. I mean, because that's the question. I mean, I could certainly be way overthinking it. That's completely possible. But if, you know, so if someone's doing research on, you know, government spending in other countries post an invasion, you know, that could be done for the last 200 years since there's been modern conflict, how much one government would spend to facilitate their will on another country after they take it over. Then that would, you know, make a difference if, like, these two situations, because there was such a big difference between our involvement and therefore money spent. You know, that's like, I guess that's part of the issue with social science as well in general, is that there's always going to be competing definitions. So someone could come along and say, I'm completely wrong, and they wouldn't be incorrect in that. You know, this is just how I took it from the definitions we were given before. Sure.
And are there other examples, right, where you know, people have started to reassess, you know, some definitions? Maybe not here in terms of.
Well, for me in particular, it was with really old wars where because they were much smaller conflict. They weren't across the world from each other. It was like actual competing, maybe city states or whatever. Those can be complicated because the nature of war has changed. You know, they might not, you know, things were a lot more tumultuous in the past. So now when these things are when we're in this weird middle state between conflict with a third party force like the Taliban now in Afghanistan or insurgents in Iraq until 2015 or whatever, you know, it is just so much more complex, and it probably will continue to get more complex.
Yeah, for sure. Okay, great. Are there any other questions that folks may have?
Remy, this is Jessie.
Hi.
I was going to type it in the Q&A, and then I'm like, whoa, okay, this may take a little bit. No, this is so interesting, and I love the lens that you viewed this and presented it. So have you always had interest looking at previous wars, conflicts?
Oh, for sure. Yeah, I've taken 4 or 5 conflict-based classes. Occupations in particular was just started a couple semesters ago when I was doing that research for him and for my mentor. And it was just that's when I really took off for me with that particular variable. But yeah, conflict in general is, especially modern global conflict, has always interested me for sure.
Fantastic. Well, you did a great job.
Thank you.
Yeah, no, that's great. And I like it too, because I read a lot of history books. And so I've been making my way through, you know,
Awesome.
Civil War and Revolutionary War text and things like this, and leaders in those fields. So it's a good personal interest of mine as well.
Ooh, awesome.
Okay, well, I think that is it, Jessie.
It is. So that wraps up session 1 for day 2. And thank you to all of our presenters, the mentors that attended, and especially thank you, Dr. Risco, for moderating this session. And again, thank you all. You all did a fantastic job. If you all want to stick around, session 2 is going to start in about 15 minutes. And with the Chelgren Fellows, and that's another interdisciplinary session. All right, thank you all.
Yeah, you guys did great. Thank you.